put something in the chat box as well. So my name is Sharon Karina. I am a pharmacist by background, and I work at Pear Therapeutics. And we have the first and currently only FDA authorized prescription digital therapeutics for SUD and OUD. So as you can imagine, prescription digital therapeutics, if you have not heard about this yet, I am not surprised. This is a brand new space, and we are one of the first companies to get that FDA authorization. There are prescription digital therapeutics that are FDA approved and being prescribed for other therapeutic areas. However, for SUD and OUD, this is really unique to us. Just a couple of things. Prescription digital therapeutics, Pear doesn't like to call them apps, but effectively it is an app that a patient would download onto their phones, so they have it available to them. The prescription process is all done through a specialty pharmacy, and it is texted directly to the patient so that they can get onboarded and get access to the app immediately. So I am going to share my screen and just go over a few slides that kind of give a description of what our prescription digital therapeutics are, some of the clinical evidence behind them. And then I'll also show you a couple of slides, because I'm a visual person, of what the patient would actually see on the apps, as well as what the providers see. When it comes to the harm reduction space, what we're really looking at is trying to touch patients who are just on the cusp of being ready to move into their recovery journey. And I'm sure, as you guys know, you never really know where somebody is at. They might be in that pre-contemplation stage. They may be actively thinking they're ready to move into their recovery. And of course, there's opportunities to capture patients really everywhere. So initially, when we got our FDA authorization, there was a lot of big push to go to intensive outpatient treatment programs, some inpatient programs, et cetera. But because of how ubiquitous SUD and OUD is, and the explosion, unfortunately, during the pandemic and some of the backsliding that's happened, we really recognize that there are a lot of patients everywhere, patients as people. As background, my mom actually was a chronic pain patient, and she started abusing and misusing her medications as well. So I understand the impact of it. And of course, being around other folks working in this position and hearing the impact of our prescription digital therapeutics on individual patients' lives is just so rewarding, because even if you could just touch one person, it has a domino effect. So let me go ahead and share my screen so that I can go over just a little bit about what Reset and Reset Out is. Give me one moment. Okay, can everybody see this okay? Let's see if we can pick this presentation mode. All right, fabulous. So I'm just going to skip through a couple of slides. I apologize, because I want to hone in on one of the most important aspects of the prescription digital therapeutics. So our prescription digital therapeutics are apps. We have one that's FDA authorized for OUD specifically, and then one that's authorized for SUD. And it could be polysubstance use, right? So we all know that fentanyl contamination is quite nearly in everything. I had a conversation with some folks in the state of Alaska that have found fentanyl contamination in street cannabis, fentanyl contamination in stimulants. So we are unfortunately hearing a lot of patient experiences where they're getting exposure to some sort of opiates, even when they think they're just using stimulants. As a matter of fact, one of our patients, or rather our providers in the state of Michigan, with a pilot that we're running, had moved from, or what they thought was from, using fentanyl, and then switched over to stimulants, and then said, oh, wow, you know, actually the stimulants are much better. I believe it was meth in this case. And they didn't have any withdrawal symptoms, and they were thinking they were making a good decision in terms of their own harm reduction measures. But come to find out that methamphetamine was actually contaminated with fentanyl. So it's been kind of an interesting journey across the board. So both Reset and Reset O are apps that combine 3 different components of treatment. We have cognitive behavioral therapy modules, so it's on-demand modules that the patients will go through in order. So they will complete lessons. The recommendation and the way that we were studied through our randomized clinical trials was 4 lessons per week. In addition to that, there's a couple of other components that include trigger and cravings that the patient can input, an intensity scale as well. And because it's an app or a prescription digital therapeutic, that is all captured in a very HIPAA compliant manner in what we call a clinician dashboard. And I'll show some visuals of that a little bit later. So really, this is a tool for patients to lean into when they don't have access to maybe their peer support specialists, or they are out and they're not engaging with their treatment teams. Or we do have some people, although it's not been studied this way yet, using this as a stopgap for patients that are not engaged currently in treatment, and they're looking to say, okay, could this be used as a tool to try to transition patients into treatment when they're out and they're still using, depending on where they're at in their recovery journey. So the prescription digital therapeutics, all those CBT modules are available 24/7. Another point that's really important is, although the patient does need to have data or Wi-Fi to download the app from the App Store, and of course a prescription that's written by a prescriber or somebody with prescribing ability to get access to it, they do not need to have Wi-Fi access or data access on smartphones or tablets to actually use the therapeutic. The caveat with that, of course, is that you're not going to see real-time updates in the clinician dashboard about where the patient is at, what they're reviewing, etc. But the patients are still able to use this. So this is important for areas where maybe, let me give you an example. Let's say West Virginia, where we have patients in more rural areas, the Upper Peninsula in Michigan, Wisconsin area, Oklahoma, tribal nations that maybe are a little bit more rural and they don't have Wi-Fi access. So really, this is available 24/7, and we do see patients leaning into this technology after hours, which is really important. So we have the data to support that. So Reset is indicated for SUD. Both Reset and Reset O are 12-week prescriptions. So patients have access to this for 3 months. We do have data supporting both of these from our pivotal trials that I'll go over. But just for your information, this is kind of all the components that are associated with these apps. So we have the patient-facing app the patient can log into, use the modules, put in their triggers and cravings. They can self-report use, which you may be surprised that people are actually utilizing that. But I think because you're not face-to-face with the patient at the time, perhaps they feel a little bit more comfortable. And also another important point that I want to bring into this, why are patients using it? We do include contingency management. And so if anybody's unaware of what contingency management is, it is an evidence-based practice for substance use, where engagement within the recovery journey, the patients are rewarded in different increments intermittently. And this is all included within the prescription. So effectively, the patients can earn rewards. We were studied up to around $500 in rewards over a 12-week period. However, with some different funding sources, such as SAMHSA funding, there is a contingency management cap of $75 per year and no more than $15 per occurrence. So we can work with that as well. But the patients will go through, they'll set up their profile, they'll kind of go through a few screens to orient themselves, and then immediately they get a $5 virtual reward. What's important with this is, one, you don't have to do like a fishbowl process or anything like that other contingency management programs have, but two, it keeps them engaged in the CBT modules and also with the product itself, which then in turn keeps them engaged with the treatment teams. So all that information will be available on the Pear MD clinician dashboard. Again, I mentioned there is real-time patient data that becomes available, with the caveat that if the patient isn't actively connected to data or Wi-Fi, then once they reconnect, you'll see that information in the dashboard, or the prescriber will see that information in the dashboard. And we also have something called a patient services center. So we do have case managers that are available in a call center to the patients if they have any problems, if they have questions about the product, and they can communicate with them in a HIPAA compliant manner. They can also communicate with the treatment team in a HIPAA compliant manner. But I do want to stress that this product was not designed for emergency cases. So there is no connection to emergency services if a patient is having an emergency. And there's also no way for the patient to enter free text into the app to avoid that situation. So it's not designed to be a connection in case of a medical emergency, etc. I'll gloss over this. We do have security and privacy practices in process because we are FDA authorized, and we're also approved by Medicaid in 2 states now, which is really exciting for a new product like this, where CMS is not really quite sure where we fit. So in the states of Massachusetts and Oklahoma, we do have Medicaid coverage, which is exciting for me. And in several other states, we are actively doing large-scale pilots for Medicaid and underserved populations. So I'll give you a couple examples. We do have one pilot that is currently launching in the state of Michigan. We have a pilot launching in the state of Wisconsin right now. We had a pilot in Indiana. We have a pilot in Kentucky. We're in Ohio. We just launched in South Carolina, or will be launching in a correctional facility for people who are currently incarcerated. So we're looking to see where can this be of value to people who are ready to engage within recovery, so that we can capture them and make sure they're not lost to follow up. So if there are any questions after this presentation about the nuances with security and privacy, I have all the documents with that, but I'm happy to share that at a later point. We're also available in Spanish now, which is really exciting. So the CBT modules, although they are written, and they are written at a 5th grade level, the patients can also listen to the lessons. So there's an audio function that they can click a button right on the app, on the module they're on, and if they choose to, they can listen to the lessons as opposed to reading through them. So here's the exciting part for me as a pharmacist. And this is really the reason I came over to Pear Therapeutics. I've been here for 1.5 years. And previously, I was working within the continuing medical education space for infectious diseases. So I was working with IDESA as well as the Society of Infectious Diseases Pharmacists. This is really a passion place for me, and one of the reasons why I'm really excited about the harm reduction aspects because of the transmission of Hep C and HIV and other bloodborne diseases. So with Reset, again, which was indicated for SUD, we've shown more than a 2-time increase in abstinence rates, as well as a 13% increase in retention and treatment and recovery services. This is with treatment as usual. So that's really important to point out. So these are patients that are currently doing treatment, where they're actually engaged with a treatment team, whether it's peer support or recovery services. So adding this treatment modality on top of it has this huge additive impact. For Reset-O, which was indicated for OUD and studied with transmucosal buprenorphine, which, I do have to disclose that, being in the commercial side of a kind of a pharma company, we have a 14% increase in retention, treatment, and recovery services over treatment as usual. So these are folks that are coming in and they are using their transmucosal bupe in this case, and against patients that were just in treatment as usual versus patients that were in treatment as usual with the addition of Reset-O at their fingertips, at their disposal, there was a large increase in retention, which is huge and very, very exciting. I'm going to skip over this. This is more important data for states that are looking to save some money, but we do have a lot of really great information about how there has been cost savings, specifically with refills, which is important when you're thinking about patients that are kind of coming in and out of the health system for various issues that are related to their SUD or OUD. I did mention earlier that these patients are leaning into the technology during non-clinic hours. So really in their moments of need, you know, even if it's at 2 a.m., we are seeing patients utilize this product. So it's become a recovery companion effectively. The dashboard is here. We'll go over that a little bit more. And I'm sorry, I'm in presentation mode, so I'm trying to go through and see what's most important. Let me back out of the presentation. Here we go. Give me one moment. We're going to switch over to another deck so I can show you what this actually looks like for the patient. So right now, you can download the apps. You just can't get access to them. So they're on the app stores for any iPhone or Android phone. Once the patients are prescribed, they will get a unique access code that allows them to access the prescription. This will always be tied to that patient. So sometimes we get questions about, well, if we have someone that's prescribing this to a patient and they only use it for a month or something like that, can we transfer it over? And unfortunately, just like any normal prescription, no, because it is directly tied to that patient and their progress. But what the patients will see, they'll download the apps, whether it's Reset or Reset O, they'll be able to redeem the access code. These are just a lot of screens showing you the process for entering a password. This is that section where I said the patients will kind of get a little introduction to how to use the app and what the whole purpose of this is. And again, it's reinforced by that contingency management. So they'll automatically get a virtual reward that they can redeem at retailers like Amazon. We have McDonald's, you know, and some patients have actually saved up all of their contingency management. One patient actually saved up for a pair of shoes, and they shared with their treatment team. It was so that they could be reminded that every step that they take is a step within their recovery. So it was a constant reminder to keep it top of mind whenever they felt like they wanted to use. Another patient had actually saved up their contingency management to get a wheelchair ramp so that one of their family members could get access into their home. And then we have patients that are actually saving up even for McDonald's or Wendy's to take their kids out or to get school supplies. So sometimes there's this misunderstanding with contingency management that people think, you know, hey, you know, these people are just going to go out and, you know, it's just giving money away. But really, we're finding a lot of patients are turning around and using it to better themselves and better their lives. And that's part of reducing the stigma, right? I know that you guys are aware of this because you're in the harm reduction space. Unfortunately, even as pharmacists, we still see the stigma in healthcare with practitioners in a wide variety of settings. So it's constant education and re-education that we're kind of facing, especially in a situation right now where it is really just so ubiquitous. So there's a couple of other things that are kind of cool about this. Treatment teams that do urine drug screens can opt to add the urine drug screen results into the clinician dashboard. And what that means for the patient is that if they end up with a clean screen or they end up with no substances of concern, then that gives them an opportunity for another contingency management reward. So there's a lot of intermittent reinforcement practices that are put back into the product, and it gets integrated into treatment depending on how this fits.
Hey, Sharon, I'm sorry to interrupt. I don't think we can see the slides that you're switching to.
Oh, no, really?
Yeah, it looks like we're still at the introductory slide.
Interesting. Okay, let's try this again. You would think that, you know, technology would.
There we go.
Oh my gosh. Well, I apologize for that. Now we're back to square one. So let me do this really briefly, just so you can see. This is what the patient is downloading from the App Store. This is what they see. Here's the screen to redeem the access code. And then we'll skip down to that part where I told you they get their first contingency management reward, where they start getting integrated with the app and how do you navigate around it. There's some notifications that patients can set up when they onboard that I didn't talk about. So this is not an app that patients are going to get spammed with reminders and messages. It's up to the patient on what they want to do. I think this is particularly important for like daily buprenorphine, right? So they can opt in to get reminders from the prescription digital therapeutics from Reset O to get that daily buprenorphine if they're on MAT. So we'll skip down. This is kind of what the contingency management wheel looks like, but it's actually being redesigned at the moment. So the good thing about being a prescription digital therapeutics company is that there is continuous quality improvement and feedback from our patients, from our providers, and also from other teams that are engaged with this to ensure that we are providing the best technology possible that's making the most impact. But effectively, they get a spin of the wheel. And sometimes if they don't win a monetary reward, there's, you know, really motivational, you know, good job, et cetera, et cetera. And within contingency management, that still works. There's also no way to game the system. So you can't have a patient that's going through all the modules to get all the money up front because of our proprietary algorithm. It will not allow them to do that whatsoever. We have not had that experience with any patients, but sometimes that comes up as a concern whenever we're kind of giving education and background on the apps. So let me move through and show you kind of a little bit of what they see. So I mentioned that 4 lessons per week is really recommended. We do have some patients that do a little bit less, and we have some patients that do a little bit more. After each lesson, we have fluency training. So that's another evidence-based practice where effectively it's kind of a quiz over the content that they just reviewed. They're not graded on it, so there's no, you know, risk of making anybody feel bad for not absorbing the information. But to reinforce the learning process, the questions are asked in different manners, and it kind of walks them through the process of really understanding the content of the modules. Patients can also repeat the modules that they've done. So we've had some stories from treatment centers and counselors who had noticed in the dashboard, you can actually see how often a patient visits a particular module. And I believe one of their patients was visiting one specific module about 6 or 7 times, which was a little unusual and kind of noted a flag for the counselor to have a conversation about it to see what was going on in it. And they had found out that the patient was sharing that module with friends and family because they felt that that module could articulate where they were at in their recovery and the challenges they were having better than they could themselves. So it became a really powerful tool, even for friends and family, and for other folks to really understand what that experience is. Again, just in hopes of reducing the stigma. And I have my own, you know, kind of going into my own personal journey with my mother. It was very difficult for me to walk through that when my mother was using. So I can understand, you know, from that aspect, how difficult it can be for friends and family who don't quite get, you know, what is using and what is recovery and what does recovery really mean? Because we're walking away from, you know, recovery meaning complete abstinence, because that's just not how it works. So I think, these modules have been very helpful in a lot of really unique ways that as an organization, we weren't anticipating. And I think as the treatment teams were walking through it, they weren't anticipating either. So I hope that we will have some case studies and things that'll get published upcoming, especially as we have these larger scale pilots that are getting launched across different states, to kind of share feedback on what is happening and what the utilization actually is. So we talked about the cognitive behavioral therapy modules. Here's just kind of a screen of what that may look like. So again, the patients kind of have to walk through this in a chronological order. There's about 26 lessons, and then there's supplemental lessons after that. So if they complete all the lessons, then there's additional supplemental lessons that they can go into. And we do have some patients that do that. We did have some patients, or rather prescribers, who had decided to do refills for patients because patients were asking to get another 3-month prescription to lean into the technology. And so they don't have to start over with that either. If they decide to get a refill, then it still saves where they were at, all the progress, and they can continue to lean into the technology. They can continue to look at the lessons, etc. So it's been a really interesting journey to see how the utilization goes through. So I talked a little bit about the fluency training. Again, these are kind of those quizzes where the questions are asked in different manners to reinforce principles of learning. And then contingency management, they get to spin this wheel after every lesson that they do. There is that check-in feature too. So sometimes patients will report triggers and cravings, and there's a scale that they can do, a scale of 1 to 10. So here's kind of what this looks like. I did mention, right, there's no free text form in there, and that's by design, because if a patient is experiencing a medical emergency, we don't want them to input that type of information. They need to contact 911. But this is really interesting because not only does it track their self-reported triggers and cravings and the intensity, but in the clinician dashboard, you can see the date that this happened. So we have some folks that are working in treatment teams that will notice a pattern. Let's say, for example, every Thursday, one of their patients really felt a need to use, or perhaps they were using. And so that just gives a jumping off point for the treatment team to talk to them about it. In this case, that patient was actually dropping off their child to their ex-spouse. And so that was a trigger for them, and that really empowered the treatment team and the counselors to prepare the patient with tools to manage it much better whenever they were faced with that type of scenario. So this is quite a bit of information. And before I move on to the clinician dashboard and what the treatment team sees, I want to take a moment and just see what questions you guys have.
Hi, this is Jill from CLA. I'm also a practitioner. I'm a PA, and when I see some patients, I work in a rural area it's pretty poor. So what do you do with patients that may not have, if they're an older patient that isn't technologically savvy, or if they don't have access to a smartphone? Is there a way? I know that that's becoming less and less of a concern, and most people have one, but there are still some patients that I could say that I see only have those little flip phones that aren't necessarily going to be able to manage an app, or they're an older patient who's not very good with technology at all. How this would be absolutely not an option, or is there any option that we could think of for them?
Yeah, that's a great question. Unfortunately, the technology is only available on a smartphone or a tablet. So if the patients don't have access to that, then it would not be a good fit for them. We are finding that older patients are actually able to navigate through this pretty well, but it depends on your patient, right? So it depends. I just go back to thinking about in my training as a pharmacist, health literacy, right? I've had experience with a very complex diabetic patient and her health literacy was very, 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 very low. So even counseling on, appropriate measures for, her insulin usage or checking her blood sugar was exceptionally challenging. I don't think that you should ever give up on any of this, and I hope that Pear can come up with a solution for that. I do know that we were looking into potentially having some way to have this on maybe a desktop or something of that nature. But I don't know that that is coming anytime in the near future where we're at. So, to your point, there are going to be patients that may not be the best fit for this.
Yeah, and that's to be expected. Not everything can fit everyone 100%, but just even with that obstacle, like if they could, knowing that, this is a prescription and it's a one device, one person thing only, if they had a family member, is that something like appropriate that like if their family member had a smartphone and you could prescribe it to them and they could use their family member's phone, once a week or twice a week to get through some things? Is that an appropriate thing to have another person's device used on that, or would that be completely inappropriate?
I would say it'd be completely up to the patient and the
Okay.
prescriber in that relationship, right? So when we get into the whole HIPAA compliance issue or access, if the patient gives permission for the family member, knowing that the family member could potentially, log in unless the patient completely erases their password and then, redoes the password every time. It's really up to them, right? So the good thing about this is that while it's a prescription digital therapeutic, it's really prescriber discretion and patient discretion. We have patients, right, that have different drugs that their family members will give to them and manage their medication. So I suppose you can think about it in the same way.
Yeah.
Maybe a family member will help manage this. And if the patient gives permission to it, maybe that gets charted somewhere. The only thing I'm thinking about is like legally, if the patient then says, oh, well, this happened or that happened in terms of HIPAA, as long as you have charting that indicates the patient gave permission for it. We don't have any forms like that, but I imagine there are probably cases out in the field where patients with similar situations are kind of being handled like that. And that's actually a great question, Jill. I'm gonna talk to our sales team and see if we've had any stories.
Oh, nice. Okay.
Shared.
All right. Well, thanks. Thanks so much for the answer. Does anybody else have any other questions?
All right. Hearing none, I'm going to go back and just show you what the providers can see or what the treatment team can see. So give me just one moment. Okay, now this one I am going to make bigger because some of this is a little bit of small text. So I apologize for that in advance. So I mentioned the clinician dashboard. It is up to the treatment center, the provider, on who gets access to it. We do have some clinics that just have one access information that's shared with the treatment team. Counselors can use it. Completely up to the prescriber how that wants to be handled. Some treatment centers have their peer support specialists using it. It just depends on how your practice is set up or how you would like to have this information used and engaged. So in this example, let's say this provider has 4 patients that are currently prescribed either Reset or Reset-O. And in this example, we're going to take our fake patient, Matthew Wilson, who is on Reset-O. So he was prescribed this for OUD. So there's a lot of different cool screens in here. This is a patient overview. So I mentioned these are 3-month prescriptions or 12-week prescriptions. Up here, we can see Matt Wilson's information. He's got 45 days left of his prescription. We can kind of see an overview of what lessons he's completed within every treatment week, right? So we have weeks 1 through 12 here. If you opt to enter in the clinic visits, you can see when was the last time he came to clinic. You can also put in a reminder for in the clinician dashboard for appointments. So that's an option there. But again, if the patient is not connected to data or Wi-Fi, that real-time information may not be available. So just keeping that in mind. So we have Matt's progress here. He did 3 lessons. He's earned $30 in rewards for contingency management. And then we could see in this area, I mentioned you can choose to log urine drug screens. That will also give another opportunity for contingency management. So in this case, Matt Wilson has had 2 UDS. One was positive, one was negative. And then we have a couple of other things in the snapshot that are important. He's indicated that he did use on 2 days. And then we can also see the triggers and cravings. So we have the dates down here, and he's indicated the intensity of his cravings, and then also the triggers. And there will be more details as we go in. So we have social pressure, anger, other, which is a good point for talking. Again, we don't have any place for them to input free text by design. But if you see that and you have a patient that's connected to treatment with a counselor or with a provider, then that's a good opportunity to say, okay, I see that you had a trigger, but you put other, can you tell me a little bit more about that? Depending upon where the patient's at in their recovery journey and what support measures that they have in place. So we're gonna skip past the UDS. This is just displaying how you can input the UDS screens. You would enter if they're negative or positive. And then this is the part where I was talking about, you can see where the patient has actually gone through their lessons. So we can see in this example what lessons the patient completed. They've done 17 total. Right here, it shows that Matt has revisited 3 lessons. So there's 3 different lessons that he went through. It shows you which one it was. In this case, he revisited it, effective problem solving 3 times. It will show you the date that your patient had viewed a lesson and also the total time that they spent in the lesson. So if you see, you can see your patient spend 3 minutes in there, and that's okay. Some patients spend more time in there. So you get a better idea about how they're kind of spending and utilizing all the CBT modules that are available to them. Here's the contingency management reward screen. So this will break down what the patients have received, what dates they've received, and the reason for it, right? So I mentioned at the end of every lesson, they get to see if they get that monetary reward or if it's just, some sort of positive reinforcement, right? So Matt has earned 7 rewards. He's earned a total of $65 so far. And then you can see all the denominations here. Something I will share with you is that we are working on more frequent rewards and lowering the denominations. Part and parcel because SAMHSA's recommendation for contingency management, as I mentioned, for any grant funded activities is only $75 per year. I am keeping my fingers crossed that that's going to change. I know there's been a lot of movement and advocacy for that because contingency management does work, but at the moment, SAMHSA does follow OIG guidance. It's a little bit different with the Medicaid coverage. So with Medicaid coverage, patients are able to get the full amount the way that it was studied. So it could be up to $500. Typical rewards are somewhere within the $300, $350 range. There's also a calendar feature that you can see in the clinician dashboard, and this will tell you where those urine drug screens were, which dates. It'll also tell you in this example, because Matt's on Reset O, he has that daily buprenorphine reminder. And if he chooses to state that he skipped his bup, then it'll show you what dates that happened and when he indicated that. It'll also show you and give you an overview of the dates that he had indicated substance use, etc. So here's just a close-up of that calendar. And then we have other views and other ways to look at the data for the cravings and the triggers. So you can narrow this down right here for Matt. There is an average intensity for this week of 6. So maybe Matt's experiencing, depending on where his baseline was, a little bit more or a little bit less craving intensities. And then you can also see the indications of when he said he used. And again, with the triggers for the cravings, whatever his indications were. For Matt, it looks like a lot of it is social pressure and anger. And in this case, he's not indicating it's pain. So that is the broad overview, and that is the end of my presentation. I just want to share that, Reset and Reset O, because we're, prescription digital therapeutics as a whole are a brand new treatment category. I'll be honest, I was a little suspect of the utilization of an app with treatments because I will say that I downloaded New. And I was very excited because that's evidence-based, and I'm like, oh, I'm gonna do it. I even paid for the full year, and then my compliance dropped off, right? So I don't think I've opened my New app for like 3 months. Maybe I'll do it today because I feel guilty sharing that with you all. But the big piece with Reset and Reset O, I think, is that contingency management, right? And the value add, not only for the patient to be able to learn a little bit more about their recovery journey and the tools that they can use, and knowing that they're not alone, is that you can see on the other side of it as a provider, where is my patient at? Are they engaged? And we've just heard a lot of really surprising stories about, some prescribers thought the most appropriate patients to use this for are the ones that are super engaged in their treatment and recovery journey. But then we have one practitioner, Dr. Carolyn Greer at Bowen Recovery Center in Indiana, who started prescribing to patients that didn't fit that mode. And she was surprised to find that they got a lot of value and they became even more engaged. So she completely changed her prescribing practices. So I think, at the end of the day, you know your patients the best. I think in the harm reduction space, it's really important to at least have this option available or be aware of it, because you never know where somebody's at within their recovery journey. You could be capturing somebody who's doing like a needle exchange, and maybe that day something happened and they're like, man, I'm ready, So the point is, I don't want to give up on any of these people because I would hate to do that. I think there's a great opportunity here. We are pushing for Medicaid coverage nationwide, of course. And I mentioned Oklahoma and Massachusetts, there's coverage. We do have state pilots. We will have some on the East Coast coming up. I cannot tell you where they are yet, but it is going to happen. It just takes a long time for states to go through the contracting process. So if you're ever curious about whether a state that you're practicing in might have some sort of ability to, get access to these prescriptions, I'm going to drop my email address in the chat. Please feel free to reach out to me, and I'm happy to give you a little bit more information, whether you have questions about this presentation or if something's available within your state or something might be upcoming. In addition to that, my colleague, Sean Sadiq, is also a pharmacist, and he also works to see if there are any grants that are available across the nation that perhaps we could take advantage of to include Reset and Reset O to see where this is applicable. So we're really trying to capture patients in every single space that we can, because people need help and they might not be in treatment and recovery like what we were looking at initially at Pear Therapeutics. Maybe they're in the criminal justice system. So that's why we're moving forward with the South Carolina Department of Corrections. And they're doing something really cool where the people who are currently incarcerated, they're not getting contingency management or those gift cards through the app. Instead, they're going to give them like movie nights or canteen dollars or minimal time off sentence, right? So there's some really unique ways that people are kind of addressing this. Also for probationers and parolees, because there's more of a strict requirement, right? To try to stay on track with recovery. So there's been a lot of interest in that. Emergency departments, when folks are coming in, potentially transitions of care across all different floors, right? So we're really trying to get this out to as many people as possible. At the same time, we're challenged by getting the data, right? So I talked about Medicaid coverage. That's our big win. I'm really excited about the 2 states, but we need it everywhere. And each state that we're running a pilot in is really for the purpose of not only getting this out to patients who need it now, but also creating that data that's nuanced for that specific state, so that then we can go back to Medicaid, then we can go back to the legislators and say, this is what the impact was for your constituents, for your patients, and this is what the impact could be as you move forward with trying to push for coverage. So that's kind of the end all be all to it. I'm happy to work with anybody who's interested in the grants aspect. Sean is as well. We make grants as easy as possible at Pear, because I mentioned that I worked within the ID space specifically for continuing medical education. I know grants, sorry for my language, but they suck. It's really, really tedious. We have all the language for you, so you don't have to go through all the clinical information. It's all cited. And Pear does full support from end to end. So it's not just you prescribing and saying, like, good luck, here's a pamphlet. We have a full field team across the US that's there to help out, help educate. We have case managers. We really want this to be a successful intervention, because the clinical evidence shows that it works. And this is a space where we really, 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 really need innovation. So I will end there, and of course, open it up for any questions. And if there's no questions, Jill and Susanna, I'll hand that back to you.
All right, thank you so much. Thank you so much, Sharon. That was a great presentation, and thank you for coming back again, and sorry for the technical difficulties last month. This is a great, it's a great new venture into technology, and this is exciting. I think I see a lot of potential, so I think we'll all I think it's all exciting for us. We do have Dan Raymond here, and he is also going to give us an update on the NVHR update. So I'll give it over to him for now, and then we can finish up our agenda that I have down here. So thanks, Dan.
Thanks, Jill. And I'll keep this brief. Hi, everyone. I'm Daniel Raymond with the National Viral Hepatitis Roundtable. And we're a network of providers, patients, advocates, public health officials working to achieve viral hepatitis elimination. And one of our main projects has been called Hepatitis C State of Medicaid Access, which is a collaboration with Harvard Law School Center for Health on Policy Innovation. So some of you might be familiar with it. I'm just going to drop a link in the chat, because what we've been doing for the last several years is assessing state Medicaid reimbursement and coverage policies and restrictions for hepatitis C direct acting antivirals. And we looked at the landscape, and this year what we really wanted to do is evolve the project. Since 2017, we've been looking at 3 main categories of barriers to access. Prescriber requirements, specifically the stipulating that that therapy would only be covered if it was prescribed by a specialist, disease severity or fibrosis requirements. Many states had initially limited coverage to people with F2, say, or higher, and then sobriety requirements in terms of demonstration of a period of abstinence or engagement in substance use disorder treatment. We've seen a tremendous amount of progress around those fronts over the last few years through a combination of advocacy, in some cases litigation, leadership as states work to align their policies towards an elimination framework. And of course, we can give examples where all 3 of those persist, but we also wanted to recognize that what we were hearing from the field, including clinicians in our provider advocates network, was the imposition of more subtle restrictions. So we wanted to kind of take a step back. We surveyed providers. We convened a steering committee to really understand better what the most relevant and salient barriers are and how they impact the burden of providing care and accessing care for hepatitis C patients. So our new report is an evolution of the initial project and goes into more granular detail about the kinds of restrictions present in different state Medicaid programs. I think maybe the top line is that we've seen many states move towards removal of prior authorization, and that is the goalpost for us. That we want to make it as easy as possible for providers to prescribe and for patients to receive access to cure, and that even seemingly small or simple prior authorization requirements can result in being barriers to that process, especially for patients who may experience some different degrees of social vulnerability, whether it's transportation barriers where they can't get to clinic in frequently, in an easy manner because they live in a rural place. If you require demonstration of chronic infection through 2 different RNA tests 6 months apart, or the recognition that the clinical value of a genotype test is probably limited to nil for many patients, or that restrictions on filling prescriptions, or in one mercifully rare case that prescriptions are only dispensed for a 14-day period. Those all cumulatively constitute significant barriers to achieving elimination and run counter to good clinical practice. So if you haven't seen it yet, take a look. Please feel free to share it. I'll also put my email in chat if you have any questions about the project or want to get involved in advocacy around Medicaid restrictions, but just wanted to flag that for people who hadn't seen it. There's also a link to the launch webinar where we went over all of this when we released it last month. Thank you.
Okay, thank you so much for that update. I appreciate it. Susanna actually has some updates from the Community Liver Alliance, so I'll let her take that away and update us about the Community Liver Alliance.
Thanks, Jill. I just wanted to remind everybody this meeting happens the third Tuesday of every month at 10 a.m. Eastern Standard Time. We have really great speakers throughout the rest of the year, as you can see on the agenda. We also have our primary care Hep C treatment training program. It's a CME program for providers who want to learn how to screen and treat patients for hepatitis C, and that happens the second Tuesday of every month from 6 to 8 p.m. We also have special speakers series, and you can check all this out on our website. In August 24th, we're having a speaker on treating Hep C in a recovery setting, and we also have somebody in September speaking on treating in a perinatal setting. So we have lots of different education programs. All of our programs are free to the community, and so we just invite you to plug in. We also have a Fatty Liver Coalition meeting, not Hep C, but I know fatty liver is on a lot of people's radar as well. We have a very robust, amazing coalition, so we invite all of you to join us in any of our programs or meetings. So yeah, check us out on our website, and I thank everyone for coming today. I didn't know if anybody else had any updates on their work in Hep C or elimination before we leave. Does anybody else have anything they want to share or add? Well, on behalf of Jill and I and the Community Liver Alliance, we thank you all for joining us. We thank Sharon and Sean and Pear Technologies for their innovation in this space. We really appreciate our beginning partnership with you. They've been great to work with. So I encourage those of you that are thinking about this opportunity, reach out to Sharon and Sean and see how they, might be able to help you in your state, in your communities, with your, community patients. Also thank Daniel Raymond for being on the call and for all the great work that NVHR does and giving us an update. And again, we're always your community resource. If there's anything that we can do to help you and your organizations, the folks that you work with, please feel free to call on Jill or me or Community Liver Alliance. Appreciates our partnership with all of you. I hope you have a great rest of the day.
You too. Thanks, Suzanne. Thanks, Jill.